In the name of Lord, the most gracious, the most merciful. My name is Asima Cheema, and I'm practicing internal medicine in Maryland. I really appreciate the opportunity to talk for a student session about neurology case studies. I hope some of you will find some interesting, knowledgeable facts and may sway your career in medicine, whatever it may be. I wish you the best. I would advise whenever you start studying, please start studying with reciting Quran verses, Rabbi zidni ilma, my Lord, increase me in knowledge. I'm going to start with a case study. A 59-year-old female is brought to the emergency room by her daughter complaining of sudden onset of right upper extremity weakness that began while she was watching TV early this morning. The daughter became concerned when her mother was unable to talk in response to questions. Neurologic exam shows right upper extremity weakness with pronator drift with a right facial palsy. When questioned, the patient seems to understand what is being said, but she cannot clearly respond. So whenever some can bring up with a differential diagnosis. So after all this case study or anything, we'll do 5 minutes and we'll think what it can be. Of course, our today's topic is about neurology, so we can think about is a cerebrovascular accident. CVA defined as a sudden onset of a focal neurologic cause of death in the United States. It occurs when a blood vessel that carries the oxygen and nutrients to the brain is a clot or it ruptures. Most common strokes are the ischemic type, and the ischemic stroke happens when blood flow through the artery that supplies the oxygen-rich blood to the brain becomes blocked. Blood clots is the most often cause of the blockage that lead to the ischemia. In hemorrhagic stroke, it happens when an artery in the brain leaks the blood or it ruptures. The leaked blood puts too much pressure on the brain cells, which damages them. The high blood pressure is one of the cause. The aneurysms is another of the cause that can stretch and burst of the vessels that can cause the hemorrhagic stroke. There are two different types of hemorrhagic stroke, the intracerebral hemorrhage and the subarachnoid hemorrhage. The most common is the intracerebral hemorrhage when an artery in the brain bursts and flood the surrounding tissue with the blood. The subarachnoid hemorrhage is less common type, and it refers to the bleeding in the area between the brain and the thin tissue that covers it. Transient ischemic attack is sometimes called a mini stroke as well. It is different from the major type of stroke because the blood flow to the brain is blocked only for a short time, not more than 5 minutes. So it is very important to know about it because it's a warning sign of a future stroke. TIA is a medical emergency, just like a major stroke, and we need to do all the complete workup to find the cause. Principal mechanism by which stroke occurs are the embolic. It can be cardiogenic, it can be any embolism in the artery that can cause it. The large artery thrombosis can cause it, and the small artery thrombosis is called the lacunar infarction, bleeding, vascular dissection, and systemic hypotension. The risk factors are the smoking, high cholesterol levels, obese patients, patients with diabetes, male gender has CVA more frequently, age is a main risk factor, high blood pressure, and atrial fibrillation. There's another type called cryptogenic stroke, or also called the stroke of unknown cause. It may be very frustrating and overwhelming, but with a proper diagnostic workup and collaboration with the healthcare team, we can find the cause of the stroke and help prevent another one from occurring in the future. Another type is the brainstem stroke. So when stroke occurs in the brainstem, it depends on the severity of the injury that can affect the both sides of the body, and it can leave someone in the locked-in state. When a locked-in state occurs, the patient is generally unable to speak or achieve any movement below the neck. The risk factors for the brainstem stroke are the same as for the other strokes in other areas of the brain, like high blood pressure, diabetes, coronary artery disease, atrial fibrillation, smoking. Brainstem strokes can be caused by a clot or by the hemorrhage. There are also rare causes like injury to an artery due to sudden head or neck movement. The brain is an extremely complex organ that controls various body functions. If a stroke occurs, the blood flow cannot reach the region that controls a particular body function. So that part of the body will not work as it should work properly. So if the stroke occurs, the right side of the brain will produce the following symptoms, like it will cause paralysis on the left side of the body. There will be some vision problems, and there will be some quick behavioral changes and the memory loss. When it affects the left side of the brain, it affects the right side of the body, and it will cause a paralysis on the right side of the body. It will affect the speech. It can be mild aphasia to global aphasia. There will be slow behavioral changes and the memory loss. There are different cerebral arteries that supply the brain, And stroke should be considered who presents with onset of the focal neurologic deficit. The specific clinical syndrome is determined by the mechanism and by the vascular territory they supply, or by the affected by that cerebral artery. The blood supply to the brain is divided into two major systems. One is called anterior circulation and the posterior circulation. Anterior circulation by the carotid circulation, and the posterior is one by the vertebro-basilar arteries. The main blood vessels comprising the anterior circulation include anterior cerebral artery and middle cerebral artery. In this diagram, you can see the frontal lobe, parietal lobe, temporal lobe. This is the occipital lobe, and this region is the brainstem. This is all the cerebral arteries supplying different lobes of the brain. This green area you can see supplying the anterior cerebral artery supplies the medial frontal, and this is the parietal lobe supplying by the anterior cerebral artery. Majority of the lateral hemisphere is supplied by the middle cerebral artery, and the posterior cerebral artery is supplying the inferior temporal lobes and the occipital lobes. So this is all the territory supplied by the three different cerebral arteries. This is the medial view of the brain. This is, you can see, major part supplied by the anterior cerebral artery. This is the posterior cerebral artery supply area, and this small one on the medial view is the middle cerebral artery. On the lateral view, we can see a large territory supplied by the middle cerebral artery, this small portion of the frontal and parietal lobe by the anterior cerebral artery, this one by the posterior cerebral artery. This is another view. This is the lateral view of the brain, the medial view, and the inferior view. That is all three different supplies of the cerebral artery. Blue one, you can see the anterior cerebral artery. This is middle cerebral artery supply over here, and this is the posterior cerebral artery. This is the one section of the brain we can see over here. Again, the frontal lobe is the anterior cerebral artery supplying. The large territory is supplied by the middle cerebral artery, and this occipital lobes by the posterior cerebral artery. So when there's an infarction of the anterior cerebral artery, we can see over here, this is the image of the brain. This is the frontal lobe affected by the anterior cerebral artery infarction. We can see the hypoechoic area on this side. This is the left anterior cerebral artery infarction. On this slide, we can see this small echogenic area is in the left middle cerebral artery. It's called left MCA thrombosis. When it happens, it causes infarction there and causes the neurologic deficit. So occlusion of the anterior cerebral artery and middle cerebral artery, the patients presents with a contralateral weakness and sensory loss in the lower extremities more than the upper extremities. Patient can have a urinary incontinence, they will be confused, and they will have behavioral disturbances. When there's occlusion of the middle cerebral artery, patient can present with a contralateral hemiplegia, hemisensory loss, homonymous hemianopia with eyes deviated towards the cortical lesion side, and the dominant hemisphere involvement results in the aphasia, and non-dominant hemisphere involvement results in the preserved speech. So this is the comparison we can see. If there is a preserved speech, this means non-dominant hemisphere is involved, and these are with hemiplegia. When there's occlusion of the posterior circulation, so posterior circulation provides blood supply to the cerebellum, brainstem, occipital lobe of the cortex, and the pons. And the major blood supply that comprise the posterior circulation are the posterior cerebral artery, basilar artery, and the vertebral arteries. And occlusion of the posterior cerebral circulation presents with the contralateral homonymous hemianopia, visual hallucinations, and agnosis. And occlusion of the penetrating branches of these vessels can result in the Thalian nerve third palsy with contralateral hemiplegia, also called the Weber syndrome. And when there is occlusion of the basilar artery, it can cause the locked-in syndrome, and also called Wellenberg syndrome. I can show you in this image of the brain, these occipital lobes. This, you can see the hypoechoic areas. This is an infarction of the bilateral posterior cerebral arteries due to the blockage of the basilar arteries. So how do we diagnose? How we do the workup? So first of all, when patient present with these symptoms, we have to do the right away. First choice is non-contrast CT scan of the brain to distinguish between the ischemic stroke or the hemorrhagic stroke. It's more sensitive for detecting blood in the brain. And CT scan can be negative for ischemia within first 48 hours after the symptoms onset, where it's very diagnostic for the hemorrhagic stroke. MRI brings the most accurate test for cerebral ischemia, and the other diagnostic workup with acute ischemic stroke involves cause for the embolic sources, like we do the echocardiogram, we order for the carotid Doppler ultrasound to see any carotid stenosis, we monitor the patient on 24-hour Holter monitor to see any cardiac arrhythmias, and then we also order workup for the inherited hypercoagulability. So how do we manage the cases? So when patients come with ischemic stroke, the time period is very crucial. So TPA, tissue plasminogen activator, used to treat the acute ischemic strokes if patient presents within the window. It is a time from the onset of the symptoms is called door to needle time. And that we can start antiplatelet therapy is very useful in secondary prevention of ischemic stroke. Aspirin is considered the first line treatment. If aspirin is unsuccessful, and we can consider starting the dipyridamole or clopidogrel that we call Plavix. So carotid endotrachemy is recommended when occlusion exceeds 70% of the arterial lumen and the lesion is symptomatic. So when we do the carotid ultrasound, and if we see the occlusion is more than 70%, then can we proceed for the carotid endotrachemy by the vascular surgeons. So I would like to share with you another case. This is a 70-year-old female who had a history of coronary artery disease. She had a stent placed and history of congestive heart failure, history of hypothyroidism, hyperlipidemia, osteoarthritis, gastroesophageal reflux disease, hypertension. So her family brought her in the ER that all of a sudden she was very confused, her speech was slurred, and she was talking that doesn't make any sense to them. So when she was in the ER, right away, CT scan was ordered, and they found, I can show you over here, some lesion in the left middle cerebral artery. You can see different sections of the brain over here. And then we can see over here, the left middle cerebral artery. So we can see some acute infarction, subacute, and with hemorrhagic portion over here. So this is the left MCA. I can show you another section where you can see more clearly. See over here, we can see some hemorrhagic, this hypoechoic area. So this is the left MCA that was affected. So this patient management, since we found that this is a hemorrhagic stroke in this patient, so patient was already on aspirin and Plavix. So both antiplatelet was stopped because given hemorrhage. So both antiplatelet was stopped and the patient was monitored closely. And just conservative management was done. And over a period of time, patient improved and physical therapy worked with the patient. And just with conservative management, after repeating the scan second day, the hemorrhage was stable. It was not extending. So that's why patient was continued on the conservative management. And physical therapy keep working with the patient, and patient improved clinically. And after 14 days, after with the neurology follow-up as an outpatient, the aspirin and Plavix was resumed, given coronary artery disease with stent placed. So this is the case of hemorrhagic stroke. And before I showed you how it presents with the ischemia. So this is very crucial. Whenever we see any patient with the neurologic deficits, we have to be very vigilant in doing all the workup to make sure if it's ischemic stroke, so we can give the TPA. If it's a hemorrhagic stroke and patient is already on antiplatelet, so we can stop further bleeding. So I hope you learned some point from this small presentation. And it was a great talking to you all today. I wish you all the best in your career and try to continue to learn about the medicine. And I hope that you guys will be a teacher one day and you can see generations of medical people through your life. It's a great reward. Again, thank you everyone. And I wish you best of luck. I will share you my resources over here. And if you have any questions, please feel free to reach us. And again, wish you good luck. Thank you everyone.